Welcome to part one of our two-part series, Functional Medicine Q&A, Men's Hormones, featuring Dr. Mark Holthouse and Gavin Guard, DMS, PAC. In this series, we dive into your top questions about men's hormonal health through the lens of functional medicine.
I'm Gavin Guard. I am a doctorally prepared PA. I have some training in obesity medicine and lipidology. And I'm here with my friend, mentor, physician, all the above, Dr. Mark Holthouse. So thank you for being here, Dr. H, and taking some time to chat with us about male hormones. That's going to be the topic of today. And I guess I'll just kind of set the background for our patients who are listening. We're going to go through kind of the top 10 or so questions that we get frequently asked in practice. The effects of androgens, including testosterone, is really widespread in the body. It affects the muscle, the bone, our brain, our cardiovascular system. And so I think at least of testosterone as this metabolic, sexual, and vascular hormone. And so the first question I'd ask you, Dr. H, is what are some of the top 3 to 4, 5, maybe, if you want, signs and symptoms of low testosterone in our male patients?
Thanks, Gavin. No, I'm glad to be here and share. This is a super hot topic and it can be controversial. The problem with low T, is that the symptoms overlap with so many other diseases, things like depression in particular. But yeah, high cortisol and stress and just life wearing on people can really masquerade with the similar kind of symptom list. And not surprisingly, those same things in life can wear down and tear our natural levels down. High cortisol, we call it kryptonite to testosterone. But, when I think about it, really, we probably want to start with things that are more specific to low T. The most specific types of signs and symptoms have to do with things like decreased libido, sex drive. Ironically, not necessarily a problem with erections. Erection issues and T are actually distantly related. And that's funny because that's why everybody comes in usually. But things like fatigue, very difficult, so many things cause that, but it's certainly one of the things you'll see. Indecisive, they're hopeless feeling, a little bit amotivational. You'll see having issues, cognitive issues. These are common symptoms, signs, problems with recovery. Some of the more specific would certainly be on my list: lower sex drive, interest, delayed recovery after workouts, where it just takes you forever to feel like you're ready to go again. I might even suggest that belly fat, seeing that your waistline is growing, or a diminishing of your strength, your lean muscle mass. Sometimes it's something that just is apparent with the way your clothes fit. Other times it's how you feel and your strength and stamina. There's a hodgepodge of very generic symptoms, and there are some that are a little bit more specific.
There's certainly things that we see quite a bit of. And I don't know about you, but for me, those are things that are often overlooked, at least in a primary care setting where you're doing annual physical. How are you feeling? Blah. And that just kind of gets chalked up to aging or some other thing that really never gets addressed, I would say, thoroughly in a provider visit. You mentioned body composition. I think that's definitely another overlooked sign, if you will, of low testosterone. One of the reasons I got interested in testosterone, I was kind of forced to, because we were seeing patients for weight loss or heart disease prevention, and then we saw that they had low T. Now I got to learn how to manage testosterone deficiency and so forth. Perhaps you could speak a little bit to the stats, perhaps, of how low T is associated with body composition issues, diabetes.
Yeah, there's several drivers of body composition. They're different primarily in men and women. There's what we call a sexual dimorphism, a difference in the effects based on gender. And in men in particular, since we're talking about that, what you're looking at is the relationship that's really blossomed over the last 20 years in the literature between sugar and body fat and lean muscle and testosterone levels. And where we were initially focused on sexual side effects and sexual performance and things like that, now it's really, things have shifted in the literature away from is it safe and the sexual side of indications to, wow, there's actually data that shows that this actually might reverse um, glucose problems, issues with central obesity, problems with fatty liver, people that have prediabetes, slowing the progression to full-on type 2 diabetes. And so it's really morphed and I guess evolved beyond that. Is it safe discussion? Does it cause heart disease? Does it cause prostate cancer, which are individual topics we can have fun with at some time? To, is this a tool that we can actually use therapeutically to help guys with body composition, help them with actually losing body fat and maintaining lean muscle mass, which is a relevant question in this culture of longevity, where loss of muscle is associated with prematurely aging. Now, it's not the only hormone that's involved with body composition. Obviously, there's growth hormone. There are other pathways involved at the cell level, whether it's this thing we call mTOR or AMP kinase, these complex systems that are in balance, moving us between muscle growth and detox and longevity, and striking a balance. Testosterone has a role even at that level. And you remember, hormones are incredibly small in quantity. Estrogen, for example, is on the order of drops in a swimming pool, and yet it has these profound effects. So these molecules have profound effects at very, very tiny doses. And so the body's used to having this dance to accomplish the goals that are needed with hormones with very fine regulation. If some is good, a lot must be better mentality has taken over this part of medicine. It really doesn't jibe well with science.
And no longer is low T or what we call hypogonadism a aging male issue, right? That we've seen this generational shift over the last 50 or so years, and correct me if I'm wrong there, of low T also being present in middle-aged and even younger cohorts. I mean, one study I've seen showed that like 10 to 15% of men under 40 had hypogonadism. Can you speak to perhaps some of the drivers there? Why are we
Yeah.
seeing that shift?
Yeah, traditionally in medicine, we had different reference ranges for testosterone based on your decade of age, inferring that as you age, there was a natural progression of decline in testosterone that we were just, had nothing to control over. The data shows that's actually not true, that there's a tighter statistical correlation with what we call primary gonadal failure and low T, as opposed to what we call secondary, where it's coming from other causes. Now, to understand this more fully, those that come to us with low T, 85% of them have this secondary type where we don't really have an identifiable cause. In fact, most guys of that 85%, 89% of them don't have any identifiable cause. So that leaves about 11% of those with this secondary type that actually have a known cause, problem with the testicle, problem with the message coming from the brain. So most of the folks that present to us are secondary in type and have no known identifiable cause. And of that group, we used to call that latency onset hypogonadism or adult onset low T. There's all kinds of different words for it, but it appears that it has more of a correlation as we age with these primary failures where the testicles not working. It's only 15% of everybody. The correlation is much tighter as opposed to age with low T to comorbid disease, meaning obesity, type 2 diabetes, the four horsemen, as Peter Attia calls it, things like heart disease, cardiovascular disease, dementias, diabetes, much tighter correlation with those chronic diseases with guys having low T as they get older. So age doesn't seem to be the primary driver anymore. It seems to be that that's for the primary failure, but for the more prominent group of secondary low T, by far and away, it appears to be how sick they are. So the argument's been, are guys that are ill with many chronic diseases, do they just have low T? Or is the low T driving the chronic disease? I think that the literature shows that probably those arrows go both ways. We've really moved recently, as of July of 2023, with a very large randomized clinical trial that the FDA mandated the manufacturers of testosterone to do, to have a large, high-risk population followed for a long enough period of time to actually demonstrate safety with not only cardiac disease, but prostate health. Those were really the two biggest roadblocks. And up until March of this year, there's been a black box warning on all testosterone products. Well, it was just removed 3 months ago, and it was removed because of the Traverse trial landmark study released in July of 2023, 2 years ago. So now that we're kind of moving on from is it okay to do to, whoa, we've got data showing it's actually possibly therapeutic. Can I say that giving testosterone prevents diabetes? No, we're not there yet. We don't have that kind of data. I can say things like diabetics with fatty liver who have optimal T levels have less problems, less fatty liver, which is relevant because 33% of the population now has metabolically driven fatty liver. So if testosterone can be a part of a reduction in prediabetes moving on to full-on diabetes and making comorbid additional issues like fatty liver with diabetics less of a threat, where we kind of defang these diseases, I see us moving into using it as more of a therapeutic role.
So what you're saying there is there's this bi-directional relationship between hypogonadism, low T, and metabolic dysfunction, which kind of encapsulates obesity, prediabetes, diabetes, heart disease, fatty liver. One causes the other and vice versa, and it becomes kind of this vicious cycle, right? Where severity of the low T builds on the severity of the metabolic dysfunction. And you mentioned some fancy words, which I understand, but I want to make sure our patients understand. Secondary, primary hypogonadism, I think a lot of people are surprised to know that testosterone production ultimately starts at the brain, right? That's the factory of this testosterone production, starts at the level of the brain, where subconsciously our brain is filtering out inputs, stress, sleep, energy availability, micronutrient status, and then it's deciding, do we have the available resources to ultimately produce testosterone? And then we release a hormone from the brain called luteinizing hormone. That's one of the hormones that we will measure for a male that we're concerned about low T. And then that hormone travels through the blood, attaches to a receptor on the testicles, and then the Leydig cells in the testicles produce the testosterone, right? And so what Dr. H is talking about is secondary hypogonadism. That's the predominant cause of low T. That is where there's an issue in the brain. As compared to primary hypogonadism, that's where there's an issue in the factory in the testicles. So I think that's important to know. I think a lot of patients are surprised that that's why sleep deficiency, sleep apnea, diabetes contributes to low T. I want to move on and talk a little bit about how testosterone affects energy, mood, and motivation. You mentioned that fatigue, depression were some common symptoms, if you will, of low T. So why is that? Why does low testosterone affect one's ability to go out and do, manly things and be confident and be competitive and do good at their work and be present with their families?
Yeah, I think, and part of it has to do with those other diseases. We have plenty of 80-year-olds that don't have low testosterone, and it's often because they don't have chronic heart disease, kidney failure, obesity, or diabetes. So we know that those diseases directly tie into what's going to happen with your testosterone levels and vice versa. So it's important to realize that testosterone is not a male hormone. In fact, it's the most bioactive steroid hormone in the female body. And estrogen's not a female hormone. It's really, really important with guys in certain levels. In fact, the only real difference is the concentration between the two sexes. So when we think about its systematic effects, I mean, the body, and particularly the brain, when you talk about cognition, is covered with receptors. Probably most predominantly receptor-wise D, and then thyroid, and then testosterone and estrogen somewhere in the fourth place. So when you have tissues with receptors for these hormones, the body doesn't do things haphazardly. It's trying to conserve energy. And when it has a receptor produced on a cell, it's there for a reason. So we know that the brain is covered with testosterone receptors, with estrogen receptors, with vitamin D receptors, with thyroid receptors. Talking about cognition, at least initially, Gavin. So we've got neurologists that have written best-selling books on dementia and Alzheimer's disease who have acknowledged now that one of the 5 subtypes of dementia has to do with hormone imbalance. And that is thyroid, it's vitamin D, it's estrogen, it's testosterone. Many of our guys that present with either depressive symptoms in their mood or cognitive changes with their worry of dementias, early onset, it has to do with their optimization of their hormones. So one of the things we'll do is acknowledge, wow, this might not just be, you've got Alzheimer's, get your affairs in order and get your MRI and, try to get in some drug trial, or worse yet, get placed on one of the many Alzheimer's drugs, which have proven not to be effective. Maybe it's just optimizing their T levels, their estrogen and thyroid and their vitamin D. And so acknowledging, I think, that there are receptors for these hormones all over the bodies, not just in the sexual organs. They're in the skin, they're in the liver, they're in our metabolic organs, our spleen, our detox organs. They're in the muscles, obviously, and in our heart. And we think probably that it's these different organs that respond to these hormones that are only at their peak performance when there's optimal levels, which is a whole other discussion about what is an optimal level, because reference ranges are reference ranges. And some of the experts in this field really have set those largely aside as being relevant.
When do you think men should start paying attention to this? Obviously, we said this is not a aging male issue. We should not be relying on the sole symptom of sexual dysfunction. Don't wait until you have erectile dysfunction, low libido to start paying attention to this. In one Canadian study I saw, it was between men 40 to 60 years old, like 25% of men had hypogonadism. Is there an argument for getting testosterone checked even before having those kind of classical sexual dysfunction symptoms?
Nowadays, yes. When I started my career 30 something years ago, it was not like this. I didn't see 30 and 40% prevalences. And this is largely dependent on the read and how they define low T, anywhere from 6 to 35% of 35, 40-year-olds even. When I first started. So yes, now I would suggest adult males that are having either infertility issues, obviously, or depressive symptoms, problems with developing abdominal obesity, where you're getting a little paunch going, or you have some pre-diabetes. These are all folks that should be screened, because the incidence of new onset low T in these folks with metabolic dysfunction is so high. Even in younger men, we're seeing diabetes, type 2 diabetes earlier in life. And we know that that's one of the major risk associations with having low T, especially of this secondary type. There was a University of Buffalo study looking at boys aged 14 to 20, and the rates of hypogonadism were directly correlated with obesity when looking at controls that were not obese. And they had more impotency, they had more subfertility. Even in their 20s, we're seeing these kinds of problems. I mean, it's commonplace now when I'm talking to young couples. It's like IVF is like part of having a family. It's unbelievable. In my era, a few years ago, that was a rare occurrence when you heard of your friends and family having trouble with fertility. We know that phthalates and so many of these BPA, these what we call persistent organic pollutants now, which the World Health Organization has identified as endocrine disruptors. And this is not a woo-woo medicine complementary alternative discussion any longer. This is mainstream, acknowledging that there's been a reduction, 40% of testosterone levels and sperm counts between 1977 and 2011. That's a dramatic drop. And if we go through a drop of that extreme in the next interval like that, there will be rampant infertility when we get down to 20 million sperm per unit. We're talking about massive species-wide infertility. On the male side, I'm screening most of my men over 30 if they've got fatigue, if they have metabolic issues, if their insulins are creeping up, their fasting sugars are creeping up, if they're having trouble with recovery in the gym, maintaining lean muscle mass.
Something I'm doing more and more is even if someone feels great, just having a baseline level can be really helpful. 'Cause something else we appreciate is there's different receptor sensitivity. Someone might feel great at 400, kind of the lower end of quote unquote normal. Someone else might feel kind of cruddy at 700. So there's a lot of interpersonal variability in terms of the receptor sensitivity that's not fully captured with that blood test. I think looking at trends over time is really impactful. And I think you would also agree that men wait too long to do something about that. They don't really realize. It's kind of like watching your kids grow up. They grow a millimeter at a time. They don't really realize how much energy and vitality they've lost until they get their T levels up. I mean, that's where telemedicine really shines. We have easy access, convenience care. These are kind of sensitive subjects. So let me just recap, because the other question we get is, what are some of the more dismissed symptoms that men experience that could point to a hormone dysfunction? And kind of going through what you've already stated, we have cognitive changes, brain fog, poor concentration. We see mood changes, irritability, kind of mild depressive symptoms, fatigue, even sleep disturbances, sexual dysfunction, low morning erections, dysfunction, low libido. We see body composition changes. We'd even see anemia and bone mineral density loss, osteopenia, osteoporosis at a more severe level. My question to you is, why are these missed? Why are these overlooked? I think that's a multi-part answer, but what are your thoughts there?
I think in general, the traditional physician, I am one historically, we weren't trained to go look for it. It was something that was a passive approach. You waited for your patients to come and ask you, which is really unfortunate because some of them are embarrassed to bring those kinds of questions up. They're not going to come in and say, I have fewer spontaneous AM erections than I did when I was 25. You have to lead that discussion and make it safe, make it okay. You have to kind of defang it and make it okay. Use humor to break it up. Icebreaker. Once you get into that with guys and you break through that discomfort, things go really well and they trust you because you have their best interest at heart. But I think it's a general lack of insight on the part of the providers, not understanding the relationships beyond just low sex drive, or you're just another guy in the gym that heard about it from your buddy that just wants to get ripped or shredded or whatever the term you want to use. They're not seeing it as a metabolic marker of overall men's health. And I think when you see testosterone in that light, then it comes to your consciousness to start thinking about it earlier. So between guys not having a real correct understanding of what all it can manifest like, and the providers that they go see not paying homage to the fact that we now know it has these associations with all these other arenas in very important areas of health. You have a recipe for disaster there. So my goal is to educate as many providers as I can for as long as I can on how important it is as a marker of overall health in men and in women, but in particular in men with some of these metabolic diseases. We've got really strong connections with low testosterone.
So what you're saying is two-part. One is often dismissed. These symptoms are often dismissed as just stress. Oh, you're just getting older. This is part of normal aging. And two is both men and clinicians don't connect that body composition, sleep, mood issue to even the potential for there to be some type of testosterone imbalance. I may add on top of that the reference ranges, which I think is a whole nother discussion. I know you and I have had some back and forth on that. These reference ranges are somewhat ambiguous, hotly debated, and not entirely trustworthy. So we have to use more intuition than just seeing if something is bolded or flagged as low for patients dealing with these issues. Well, we could talk about that more. I want to move on and talk about, we've seen this hormonal and generational shift in testosterone levels in both older and younger cohort of men. We've talked about some of the reasons for that, including diabetes, obesity, driving the low testosterone, ultimately at the level of the brain. What can we do about it from more of a lifestyle perspective, and also treating like the underlying root cause of obesity and diabetes? I know it's a leading question, but you have
Yeah,
anything to add there?
you just nailed it, Gav. I mean, people come in all the time and they say, what's a optimal testosterone diet look like? What does my Aura ring need to say to have optimal testosterone? Do I need to lift weights 7 days a week or 5 days a week to have, so there's all this information out there, and the answers are very simple. The data is just so heavily stacked towards optimizing your body composition. Number one on the list is not lose weight, lose fat. So weighing on the scale is deceiving. You have to use a bioimpedance machine, which measures your body composition. What's the composition of your total weight? How much lean muscle, how much body fat, and how much body fat is visceral, hidden inside, that's metabolically toxic and inflammatory and driving insulin resistance and prediabetes. So number one always is body composition, not losing weight, but losing fat and gaining muscle. Number two is exercise. Exercise upregulates anti-inflammatory genes in our bodies. It modulates and suppresses inflammation, helps our mood. It directly, both strength training and cardio, increases both free and total testosterone. In fact, exercise increases the density of the receptors for the hormone in the muscle, what we call the androgen receptors. Gavin alluded to receptors. Receptors can be functional or dysfunctional. We call that a relative testosterone resistance when that happens, kind of like insulin resistance in prediabetes, where the cells stop listening to the signal of insulin, just another hormone. So like insulin, cells can become resistant. We know from a genetic perspective, people have variations in the functionality of their receptors. But exercise can really help as a workaround things like that. You don't have the choice of choosing your parents and the genetic SNPs and mutations that we have on things like that. But we do have a choice on our body composition, what we eat, and a regular exercise program. So those are one and number two. Number three, which is right in there, is managing stress. We say cortisol is kryptonite to T because cortisol is just another hormone. And we know that it's a catabolic hormone. It's like prednisone. It tears us down. It causes us to lose lean muscle mass, lose bone mass, lose our structure, the things that hold us upright, and we gain belly fat. So when you've got poor sleep that's driving high cortisol, which, by the way, cortisol is supposed to peak in the morning when you get up and be at a very low trough level when you go to bed at night and stay down there till you start to get into the wee hours of the morning when your body's revving itself up to get ready for the day where it's peaking. A lot of people have spikes of cortisol at night, which raises their sugar and it's interfering with their T. So sleep is a big deal with natural T because it's pulse dosed from your brain at night. Both growth hormone and testosterone are pulsed hormones. They're not just on or off. So at night when you're sleeping and you're dreaming, REM sleep is when you're secreting from your brain the message to make T. And when you're in deep sleep, you're secreting growth hormone from the pituitary. Both of those are building anabolic hormones that repair and recover you from the day prior and regenerate your body. So if you're not sleeping well, you're not secreting growth hormone, you're not secreting adequate testosterone, and you're getting excess cortisol. So managing stress to keep that cortisol down, managing sleep, treating your apnea.
Snoring, gasping for breath, needing daytime naps. Those are some of the
Right.
things we ask about.
Yes, and it doesn't have to be an overweight person. We found this to be true in even 100-pound, 5-foot females. You know, it's not just the linebackers, the cheerleaders we got to think about, right? So we see sleep apnea undiagnosed all the time, and this will raise a level of cortisol at night, often leading to awakening at 2, 3 a.m. So that one of the bigger symptoms we see if you follow the ball with low T, people that have sleep disorders, you know, whether it's due to untreated apnea or chronic pain, these are all things that raise cortisol levels beyond just financial stressors and the things we deal with in life every day. So
So
those are
someone
probably the big four.
someone works on their nutrition, they work on their stress, their sleep, and anecdotally, you know, this is why I want to become more specialized in weight loss medicine, because I saw that that was kind of the root cause that led to improvement of blood sugar, testosterone, lipids, heart disease prevention. I try to get my patients, like, they get 3 gold stars if they get 10% weight loss, which often they're at 10% and they get disappointed because they want more, of course, but like just to be healthier, 10% weight loss, some of the studies I've seen can raise testosterone by about 100 points, which is notable, but for many men that may not be enough to work on just diet and lifestyle. So for the guys who are accustomed to those healthy habits, who want to go to the next step, one of the other question we want to evaluate, who needs testosterone replacement, who doesn't.
Thank you for joining us for this 2-part series. In part 2, Dr. Holthouse and Gavin will explore testosterone replacement therapy and evidence-based approaches to optimizing hormonal health. If you are interested in becoming a patient, please visit us at funmedinstitute.com to schedule a consultation.